So, good afternoon, everybody. Thank you very much for joining me. My name is Chris Jenner, Dr. Chris Jenner. I am a consultant in pain medicine at Imperial Healthcare NHS Trust. And today we're going to be talking about defense strategy in chronic pain cases. So, the agenda for today, what is pain? A bit about pain physiology. We're going to look at the anatomy of a pain report, how we analyze a pain report, and there'll be plenty of time at the end for questions. Just to say, if anybody wants to, so I can either see them or hear them, it's quite nice. Otherwise, I'm just talking into a dead computer. Right. So, what is pain? So, the definition of pain, it's an unpleasant sensory and emotional experience which we primarily associate with tissue damage or describe in terms of tissue damage or both. Now, obviously, that's quite a mouthful in terms of definitions. As pain clinicians, we look at a couple of things with pain. First of all, the time course. So by definition, acute pain is less than 3 months and chronic pain is greater than 3 months. We also look at the type of pain that the patient or claimant describes. And the main two types are nociceptive pain. That's where the pain signaling pathways are intact. And neuropathic pain, where there's damage and or dysfunction to an element of the nervous system. Neuropathic pain, patients describe very florid types of pain. So they'll talk about sharp, cutting, burning, lancinating, stabbing type of pain. So pain physiology. Well, if we look at regular pain physiology, to be fair, it's pretty dull. It's all about receptors, receptor subtypes, neurotransmitters, areas of the brain interacting, midbrain, brain itself, and it is fascinating, but it's very hard going. And so for that reason, we're hopefully going to have a slightly more entertaining and hopefully educational view of pain. So here we go. So first of all, we have a nociceptive impulse. Now, obviously, this is a pinprick here. It will activate what we call nociceptors or pain receptors. And this is the propagation of a signal in the alpha, the A delta and C fibers. And these action potentials or electrical stimuli going back up to the spinal cord. Here they're going into what we call the dorsal horn of the spinal cord. And they will activate neurons. These are other neurons which are being activated here. And this goes down to a synapse where neurotransmitters are transmitted across this so-called synaptic cleft. When they get to the other side and you see them just hitting the other side, they cause an action potential to be propagated. And then there are multiple different pathways in the spinal cord which ultimately end up in the brain. Now, this is very important. Unlike things like the cardiovascular system or the cardiovascular center and the respiratory center in the brain, there is no actual pain center in the brain. But what there are lots of different areas which subserve different functions. So, for example, it'll give you information about where the pain is, what the intensity is, what you're going to do, if there's a reflex response, if you're going to stay, if you're going to fight, if you're going to run away, and all the emotional and behavioral aspects of pain as well. So let's look at the anatomy of a report in pain medicine. So we start off with a summary of the case, usually provided by the legal team. I do a detailed PreIndex Events medical records summary, and then the same for the post-index events. If there are any employment records, we look through those, any information about sick leave, DWP records, again, if they're available, and physiotherapy records. And essentially, these are all put in chronological order. If there are any claimants' expert witness reports, then I will summarize that. Any defendants' expert witness reports, I'll summarize that. And obviously, if there are any joint reports, we'll look through that and summarize it. We then move on to the witness statements for the claimant and for others. The next thing we have is a section on the history of the patient's pain. Now, approximately 2 to 3 weeks before I see a claimant, we will send them out a detailed pain questionnaire, and that will ask them questions about their pain. So things like site, character, duration, radiation, aggravating, relieving, associated factors. So all the sort of description of their pain as they find it. We'll ask them about their function in terms of employment, what they can and can't do, their care requirements, interactions with family relationships, etc., etc. So we try and get as comprehensive a view of their pain as we can. We also send out pain questionnaires. These are standardized, validated pain questionnaires. So ones you might have heard of are things like numerical rating scales and verbal rating scales, which give some sort of score for the patient's pain. I do an examination, which we're going to talk about in a minute, and then give a conclusion about the claimant's pain. So examination, I mean, one of the most important reasons for seeing patients face to face is the hands-on examination. And essentially, the examination starts the moment the patient opens the door, or I open the door to them and they walk in. We're looking at illness behavior. Have they got a wheelchair? Have they got crutches? What's their affect? How are they behaving? Who have they brought with them? Have they got a chaperone or a friend, or any other sort of general information that can be gleaned essentially when they come through the door and sit down and present themselves to you. I'll then do a targeted examination, and the patients will usually in advance on their pain questionnaires make it clear where the areas of pain are. And then I will do a targeted examination of that area. So, for example, if it's neck pain, it would require a cervical spine detailed examination of the neck, the paravertebral structures, but also an upper limb neurological examination. So things like tone, power, reflexes, and light touch, pinprick sensation for completeness. And obviously, every area of pain and every area of the body has a very specific targeted examination that we do. And this includes inspection, looking at the area, and palpation, which is prodding, pressing, examining the area and trying to elicit pain. The other thing I do when I'm face to face with the patients is I do have other questions. Now I have a list of about 34 questions that I ask, and these are all the domains that we've really spoken about earlier. But it just gives me an opportunity to get further information, if necessary, from the claimant. Just to give you an example, recent clinical negligence cases, certainly surgical procedures, post-surgical pain, that's very common, post-surgical neuropathic pain, severe life and limb threatening issues, interventional procedures. We've had epidurals, so lumbar epidural leading to paralysis, pretty catastrophic, cannulation and intramuscular injections leading to neuropathic pain and complex regional pain syndrome. Quite a lot of spinal surgery cases, patients that have had what I would call big spinal surgery, so spinal fusion with decompression and cages and complex spinal surgery, and fair amount of obstetrics, and then there are some other cases beyond that. So the conclusion, once we've got all of this information and we've summarized it, we've put it all together, then we need to analyze it. So this is in the conclusion section of the report. So we start off with simple things. The pre-index events summary. I will divide this into three, into the pain-related entries, psychological and psychiatric entries, and other health issues. So we get an idea of how the claimant was before the index events. We want to know, did they have an actual pain disorder? Or was it just episodic pain they had, intermittent lower back pain? Or did they have ongoing neuropathic pain or ongoing fibromyalgia or chronic widespread pain before the index events? Did they have any psychological or psychiatric disorders? Now, the two commonest we see, I would say by far in any of these types of reports, is a pre-events history of depression and anxiety. And we'll talk about that later, but that's very important when we look at how patients present with their pain and the effect of depression and anxiety on that. Did they have any vulnerability before the pre-index accident or pre-index events, physical, psychological, psychiatric? We then look at the index events summary. So what we're looking at is the instruction from your good cells will give us an overview of exactly what's happened. So that's a good starting summary. I then look at the contemporaneous records. So that's usually A&E records, hospital records, GP records, etc., etc. And then we look at the claimant's description and the events details, and it's really a case of cross-referencing all of those. Does it all make sense? And the important thing at the end of that exercise is the plausibility of the index events causing the symptoms that are reported by the claimant. The next thing we're interested in is an evolution of the pain and any other symptoms that the claimant complains of. So this is in the immediate aftermath of events, in the following days, in the following weeks, in the following months. And as was pointed out to me recently, it is possible to work out how patients' or claimants' pain has altered following legal advice, which was very interesting. We want to know, has the claimant had appropriate treatment? Have they been compliant with the treatment they've been offered? Were there any delays in seeking treatment? Has there actually been a resolution of their symptoms? Has the claimant been discharged from medical care? So that may be from the physio, from a hospital department, from a pain clinic, etc. DNA did not attend. This is very important, particularly as these claims roll on, patients not turning up for their appointments. Why not? And is there any evidence of secondary gain? Now, I've put this up. The fear avoidance model of pain is, in simple terms, a model where injury causes a pain experience. Now, where there is low or no fear, a claimant will confront that injury and essentially recover, get better, and that's the end of it. However, if patients catastrophize, which we'll talk about in a minute, they can have a fear of movement, which is kinesiophobia. They can have avoidance and hypervigilant behavior. They disuse the limb or the area where they have the pain. It can affect their mood, which therefore affects their pain experience. And as you can see, the claimants will go round and round this merry-go-round, essentially. So what's catastrophizing? So catastrophizing is defined as a cognitive distortion that prompts people to jump to the worst possible conclusion after a relatively minor setback. When a situation is upsetting, but not necessarily catastrophic, they still feel that they are in the midst of a crisis. They will get unnecessary and persistent worry, which can lead to a heightened anxiety and depression, and that can lead to a increased presentation with pain. And of course, the one thing that we're always asked about is reliability and veracity. So I view this as what I call the continuum of exaggeration. At one end, I think there's relatively innocuous, unconscious exaggeration. And at the other end of this continuum is conscious exaggeration. If we're down at the unconscious exaggeration end, this is really where we're talking about is the claimant trying to convince rather than deceive the medical professionals seeing them. And then we move through this much grayer area where patients may be embellishing their story or adding to their story. And ultimately, this leads to possibility of fundamental dishonesty. In my experience, most of the patients I see lie somewhere in between. So fundamental dishonesty certainly does happen, but not hugely often, but certainly I've seen it. Most of the patients are really there trying to convince rather than deceive, and they do tend to embellish their stories. How do we work out a patient's reliability and veracity? Well, certainly inconsistencies are important. And as I've put here, the claimant's story versus the medical records. I mean, simple examples are patients that present to us and say, yeah, I've got all this pain. This pain is terrible. I can't do this. I can't do that. But then when you go through the records, you'll find, say, a physiotherapy entry saying, Mrs. Bloggs is doing extremely well. She's able to do A, B, and C. She's doing these exercises. This is good. That's good. I've now discharged her from my care, which clearly they're doing well. Alternatively, you may see patients that DNA do not attend, so they've had appointments made, but they never turn up. A one-off is one thing, but when you see it as a consistent pattern of behavior, then you have to ask the question, do you really have a pain issue? Because if you did, you would probably turn up to your appointments. We look at surveillance evidence if it's available. And as I say to all the lawyers, I'm sure you all have some amazing stories about surveillance evidence. Certainly, I've seen some corkers in terms of surveillance evidence, and we could have a lecture just on surveillance evidence. But I would say, as a generality, surveillance evidence is not always that helpful. Generally speaking, the surveillance shows that claimants have a relatively sedentary lifestyle. They're driving around, they're walking around, they're going to the park, they're going to the shops. They're not really involved in anything really strenuous, apart from, of course, when you do see them involved in things like lifting and carrying that they have claimed they can't do. What we're finding from an expert point of view, much more useful, is actually social media evidence. And of course, this is different because the patients are trying to show themselves in a more positive light. And definitely, I've seen a trend where claimants are getting tripped up by their own social media evidence. And I would say that to a certain extent, this is more useful than the surveillance evidence in some cases. And I don't know, but it may be more cost effective to get hold of. And of course, there may be other evidence that comes to light. So then we have to work out what type of pain the patient has. Now, at the beginning, we said there are these two types of pain. We have nociceptive pain. So this will be back pain, neck pain, arthritic pain, sort of general pain that somebody would have from an arthritic condition or a musculoskeletal condition. And then we said that there's this other beast, the neuropathic pain, where there's damage or dysfunction to an element of the nervous system, where the patients have much more florid descriptions of their pain. They might have much higher pain scores. It's also possible to have a mixture, of nociceptive and neuropathic pain. And there are various ICD classifications. ICD is the International Classification of Disease. It's currently in its 11th form. It's published by the WHO, the World Health Organization, and it is quite a useful document or website. If you go and have a look at it and you look at pain, it'll show you all the main categories of pain, and then the subcategories and the sub-subcategories. So it is possible to give reasonably useful diagnoses using the ICD 11 classification. We then put in the reports a range of opinion. So in medical speak, we call that a differential diagnosis. But when we're dealing with medical legal cases, we just call it a range of opinion. And there's really three major categories. Number one, is there a biological or organic differential diagnosis? So this would be, does the person have CRPS, complex regional pain syndrome? If you think they do, then the biological organic differential diagnosis would be neuropathic pain, or it may be mixed nociceptive and neuropathic pain. Psychological, psychiatric differential diagnosis, it may be SSD, somatic symptom disorder, which we're going to talk about, mood disorder, adjustment disorder, or other issue. And at the bottom, we've got the so-called non-biological and non-psychological issues. So essentially here, we're looking at the spectrum of exaggeration, which we've discussed earlier. So just to put a bit together about SSD, somatic symptom disorder, obviously I'm a pain specialist rather than a psychiatrist, and this is the domain of psychiatry, but there is quite a significant overlap, particularly where you have claimants who have, shall we say, quite colourful pre-index events histories, and you know where they are when you do a summary and you're confronted by 50, 100, 150 entries in the medical records before you've even got to the index event. So somatization is psychological or emotional distress, which is manifest in physical symptoms that are otherwise what we call medically unexplained. It's very common, 5 to 7% of the population, propensity of females to males. There's a heightened awareness of certain bodily sensations and a tendency to interpret as this being indicative of medical illness. The patients have excessive thoughts, feelings, and behaviors associated with those symptoms. And risk factors include childhood neglect, sexual abuse, chaotic lifestyle, alcohol, substance abuse, and personality disorders. For the actual diagnosis of SSD, really you need a psychologist or preferably a psychiatrist. But as pain clinicians, we do have to be aware that there is quite an overlap between pain disorders and SSD. The biopsychosocial model of pain, really when we look at how a patient presents with pain, we're not just looking at, oh, they've got shoulder pain and, you know, it's the site is the shoulder. This is what it feels like. Their pain score's 6 out of 10. When they move their arm in this way, it hurts, etc., etc. Those are all the characteristics of the pain that we've described earlier. And that's the biological aspect of it. But there's also a psychological and a social aspect to it. So psychologically, as we said, patients are more likely to have mood disorder, particularly anxiety and depression. They may catastrophize. They may be under a lot of stress. And then socially, it will affect them. It'll affect their relationships, their employment, their care needs, their interactions with their friends, if they do or don't do their hobbies, whether or not they're in the medico-legal process, etc., etc. So when you then look at patients' presentation with pain, you go beyond just, they've got shoulder pain. You then look at their presentation using this biopsychosocial model, and this is standard in pain medicine. After the events and in the conclusion, I'll do a detailed analysis of the biopsychosocial model of pain. So we'll look at the post-index events biological factors, which are the pain, post-index events psychological factors, and post-index events social factors, as we discussed. When we move on to the question of causation, generally speaking, there will be, and this is a generality, generally speaking, there will be what I would class a primary expert in these types of pain cases. Now, usually that's going to be an orthopedic surgeon, it may be a neurosurgeon in a spine case, it might be an obstetrician in an obstetric case, but essentially they are the experts in the in the field that's the primary issue that the claimant has had a problem with. And in terms of causation, they are the experts that we go to for their view on causation. If there's any significant psychological or psychiatric issue, which is very, very common, pretty much ubiquitous in these cases, then I would defer to an expert witness in psychiatry. And if there's any other neurological or other issues, then we defer to the expert witness in neurology. Now, this isn't to say that for causation, as a pain expert, we or I would say, well, we don't know, we're pain experts, we haven't got a clue. We do, we have a very big clue. But for the purposes of the court and for the purposes of the medico-legal process, we would defer particularly to the primary experts on matters of causation. Often we can give information as to why, for example, a claimant continues to have pain, for example, long after the healing of a fracture or long after the birth of a child, etc. We can give a lot more information about that. Again, when we're looking at causation, we also want to look at the natural history of the injury. So this patient's had hernia surgery and they got pain in their groin and it's ongoing. What's the natural history of that? Should it actually, in fact, get better within a few weeks or a few months? And if not, why has that not happened? Is it time limited? And often that can be helpful to have the primary expert witness to tell us that, you know, you would expect in XYZ circumstances, a tissue will heal, for example, and the patient shouldn't have any further pain or dysfunction. And then we come in and explain why that may not be the case. Causation, we're looking at essentially from one end of the spectrum to the other. Is there direct causation with the index events for the claimant's pain? Has there been a permanent exacerbation? Has there been a temporary exacerbation? Or at the other extreme, is there no causation, no direct causation between the index events and the presentation of pain that the claimant has? We then look at prognosis. Now, this is fairly standard, and the reason is, I will say approximately X years and Y months have lapsed since the index accident. On the balance of probabilities, the claimant's pain is unlikely to spontaneously resolve. On the balance of probabilities, the claimant's pain will continue indefinitely and can therefore be considered permanent. Now, the reason I can make that generalization is, as we said at the beginning, chronic pain is defined as pain from 3 months or more. And as you can imagine, by the time I see a medico-legal claimant, the minimum is going to be 2 to 3 years, up to 5-ish years. They've had that pain for some time. So they have got a chronic pain problem by the time they come to see a pain expert. So we're just going to do a little overview of treatments and the treatments that can be offered and as suggested in the medico-legal reports. First and foremost, in pain medicine, we use a multidisciplinary team approach. So pharmacological agents, this is usually the domain of pain doctors. We use lots and lots of medications, anti-nerve pain medications, some of the ones that you will have heard of here: pregabalin, gabapentin, duloxetine. We have a bunch of other agents that we use: anti-inflammatories, antispasmodics, smooth muscle relaxants, analgesics, things like codeine, tramadol, strong opioids, morphine, oxycodone, etc., etc. And we use a principle called multimodal analgesia. So when you're confronted with a patient with pain, generally a single medication is usually not that helpful, but using small amounts of different analgesic medications and other medications in combination, otherwise known as this multimodal analgesia, can be really quite effective. That's just to say, this is the WHO's pain relief ladder. At the bottom, you'll be giving patients things like paracetamol, anti-inflammatories. You step up, you might add in weak opioids, as we said, codeine, tramadol, tapentadol, etc. And then at the top, you would use opioids. So this is the morphine, oxycodone, etc. Now it says at the top, freedom from cancer pain, because this is a cancer pain ladder, but we've actually stolen it and we use it for the same purposes, but for non-cancer pain. There are an awful lot of different psychological treatments. This tends to be the realm of clinical pain psychologists. That's psychologists with a specialist interest in patients with pain. So this can include counseling, CBT, EMDR, RTMS treatments, and also group therapy, which we'll talk about later. There are minimally invasive procedures. So essentially, this is things like injection of local anesthetics, of steroid preparations, of Botox. And this tends to be done under X-ray or ultrasound guidance. We also use technology called radiofrequency. And there's two types of radiofrequency. There's a destructive radiofrequency denervation and a non-destructive radiofrequency, pulse radiofrequency, which we use to try and treat nerves. Botox, we've mentioned, we use that quite extensively these days. And then at the more advanced end of things, we use nerve stimulation. So this is referred to as spinal cord stimulation or dorsal root ganglion stimulation. And essentially, these are implantable electrodes which are put next to the spine. And as you can see in the diagram, they're tunneled under the skin and they go to a little battery pack which has a small CPU in it. And patients will often have a handheld remote control device in order to alter the settings of their spinal cord stimulator. And essentially, I mean, it's clearly more complex than this, but essentially it's a very expensive implantable TENS machine is a simple way of looking at it. Now, physical treatments, I've deliberately put this last. And the reason I've done that is because, in my opinion, all the treatments that we offer patients to improve their pain, whether it's drugs, injections, surgery, spinal cord stimulation, whatever, all of those treatment modalities are essentially there to try and reduce pain as much as possible. But the next step really is rehabilitation, physical and to a certain extent psychological rehabilitation, all of which is done by the pain physiotherapists. So physical rehabilitation therapy includes graded exercise programs, strength, flexibility training, cross training, and functional improvement, basically improving a claimant physically as much as possible, making them less dependent, reducing their care requirements, reducing their future care requirements, and hopefully, ultimately, the aim is to return claimants to the workforce if they're out of the workforce, to get them back into employment. That's a very important function of pain medicine. When I said earlier, physical and psychological, most pain physiotherapists actually do a lot of sort of under the radar psychology with the patients to try and get them to confront their pain, get them motivated, interested, getting them to try and do the exercises themselves and make them more self-reliant, which then improves their outcome. So then we look at future employment. Obviously, the starting point for this has to be pre-index events employment. What was the claimant doing? Were they full-time, part-time, not working, in education, retired, etc., etc.? As a generality, employment is seen to be therapeutic in pain medicine and medicine, and it's to be encouraged. Why? It has psychological benefits, physical benefits, social benefits, and financial benefits. So it is very, very important not to just improve patients' pain and get them moving a bit. It's important to improve patients' pain, improve them physically, rehabilitate them physically and psychologically, with an ultimate aim of returning them or getting them into the workplace. Future care requirements, same thing. We look at the pre-index events care requirements. And again, as we've talked about, the importance of treatment is really to make patients, is to minimize their care requirements, to increase their independence. They may require some assistance with heavy domestic tasks, obviously, depending on the pain and dysfunction that they have. And at the bottom, I've put when and if you have claimants who do have more complex care needs, then really we're looking toward an expert witness in care to give us information about that. So fantastic. We've made it to the end. It's question time. Just to say, there's a bunch of us now. I have to always look this through. 1, 2, 3, 4, 5, 6, 7, 8. There's 9 of us now. It keeps going up. So there are 9 expert witnesses at Medicolegal Partners. So pain, spinal surgery, trauma orthopedics, oromaxillofacial, plastic surgery, intensive care, neuroradiology, and cardiology. And we have experts in all of those fields at the moment. So moving back, questions. My little phone is buzzing already, so let's have a look at what we have question-wise. Okie dokie. Right, so question 1, I'll just read it out. Here we go. So if you believe the claimant was consciously exaggerating during your examination, how would you approach this in the written report? Would you explicitly state that you believe the claimant is consciously exaggerating, or would you tend to be more reserved and point out the inconsistencies and leave that conclusion to the court? That's fascinating, because that's almost an identical question that I was asked recently. And my answer is very firmly, my role is to report these things to the court. It's to put them into the medico-legal report. So no, I would not explicitly state that a patient is consciously exaggerating, because you can get yourself into some pretty hot water doing that. However, there's absolutely nothing whatsoever wrong with actually pointing out what those inconsistencies are, and yes, leaving that to the courts to decide ultimately. Oh, one coming in. Question 2. Have you seen any movement towards a more holistic approach towards pain management in recent years? Yeah, definitely. I would say that since I've been a consultant in pain medicine for about 15 plus years. And certainly we are all realizing the importance of a more holistic and a more multidisciplinary approach to pain medicine. So certainly in the old days, 20 plus years ago, pain clinics were run by usually anaesthetists that did a couple of sessions a week, and all they could really offer was maybe some medication and a nerve block, and that might even be it. Modern pain management centres and pain medicine units, and the big ones are places like UCH or Guy's and St Thomas's. They have a department of pain medicine, and they have doctors, they have pain nurses, they have pain physiotherapists, they have clinical pain psychologists. They run pain management programs, which we can talk about if you like, but essentially those are group treatment activities, and they have a much more holistic way of treating patients. So yes, a much more dedicated way. Right, question 3. So given the frequent interplay between psychiatric symptoms and physical problems in personal injury cases, which would you recommend first? Psych reports or pain reports? I would say you certainly need both in these cases. I mean, to be fair, it is very helpful from a pain medicine perspective if you have a psychiatric report first. And I'm just thinking out loud here, but certainly without a psychiatric report, in certainly the causation section, it'll be right. Well, I've identified this patient has A, B, C, D, and E psychological psychiatric issues from the records. On causation, I would defer to the expert witness in psychiatry, and so you're then waiting to get the psychiatric report to comment on it. If you've obviously already got the psychiatric report, then you're in a position to say, well, I recognize that they have all of these psychological psychiatric issues, bosh, but I defer to the expert witness who is of the following opinion, and that essentially sorts out that psychiatric psychological opinion there, and then I can certainly slot that in with my biosocial model, and that would be very helpful. So in answer to that, in a long-winded way, yes, a psychiatric report first would be very helpful, and obviously the primary expert witness. So let's say that's an obstetrician or a spine surgeon or an anesthetist, or an orthopedic surgeon as the primary one, expert witness, and then a psychiatry expert witness, and then we can come in as a pain expert and say, right, well, we got the primary expert information, we got the psychiatry, and then we can put it all together and we can actually talk about how this claimant is presenting with all the relevant information from the records, with all the relevant information from our history and examination, but also with the relevant information from those experts to give us that extra information. Right. So that looks like it's everything. That's the 3 questions there. Once again, thank you very much for joining me this afternoon. I do hope that you found it helpful. If you do have any other questions or anything you'd like to ask, please don't hesitate to contact our offices, and we'd be more than happy to help you. Oh, got a little tick, hands up, thumbs up sign. Fantastic. Well, all there is to say is to everyone, I hope you enjoy the rest of your afternoon, and thank you very much for joining me. Thank you very much.